It is 6:30. We are going live. It's about a 20-second delay.
Welcome. I am Alan Benson, a facilitator of this yet another virtual event, the African American Initiative COVID-19 Summit. AAI is a policy initiative organized in 2010, featuring a wide array of primarily African American stakeholders, leaders, and operatives that come together to discuss and address issues that confront the African American community. It draws its input across Kentucky and the nation, and it is convened by many organizations that support this common objective. Our hosts for this COVID-19 summit include AARP of Kentucky and Cy Boulay of Sigma Pi Phi fraternity. AARP is the nation's largest nonpartisan organization dedicated to empowering people aged 50 and older to choose how they live at their age. It has some over 3,500 members in Kentucky alone. Pi Boulay of Sigma Pi Phi Fraternity Incorporated is the initial supporter of AAI. And we celebrate its work in the Louisville community, across Kentucky, and indeed in the nation. Now, this event is broadcast on our Facebook Live page and also simulcast through 1350 WLOU. It's going to be an interactive discussion, so please share your thoughts and questions and ideas on our Facebook Live page or by calling WLOU at 502-776-1350. Now, at this time, I would like to introduce to you our moderator, State Senator Gerald A. Neal, who represents Kentucky's 33rd District. He will introduce the co-moderator and panelists. Thank you.
Thank you, Alan. Thank you very much, and welcome. I'm very happy to see that we have another opportunity through the African American Initiative to share information that we think would be interesting, but also educational for the community. We have a very important subject matter today with respect to COVID-19. We all have been impacted by this in varying degrees, but certainly we have all been impacted. There are many questions that have arisen as this disease, this pandemic has evolved. And even though people have been affected, they've been affected in different ways. And we've reacted to it in different ways. So we have a wonderful panel of experts, people who have tremendous experience in the field and academically to address some of these issues. And we think that it's going to be informative with respect to that. In just a moment, I'm going to introduce each of these individuals, and we're going to proceed in the following fashion. I'm going to also introduce my co-host, Dr. Louis Hargett. But so that you are ready, what we're going to do is ask each presenter to give a presentation, and they will. There's 4 presenters. And after that, we will go into a Q&A, and we'll go into a discussion, a free-flowing discussion at that. So, that being said, I'd like to introduce my co-moderator, Dr. Louis Hargett. Louis Hargett is a Meharry 1987 graduate. After graduating from Meharry, he completed internships and residencies in internal medicine and physical medicine and rehabilitation at the University of Louisville in Louisville, Kentucky. He is a board-certified physical medicine rehabilitation physician in Louisville and has practiced for over 25 years. Also, he has been featured in the Greater Louisville Medical Society as a top doc and in the Louisville Medicine magazine. Welcome, Dr. Hargett.
Thank you, Senator Neal. I'm pleased to be co-moderating this event with you. It's a very important event in talking about COVID in the minority and African American communities. And I also like to say that I'm president of the Falls City Medical Society, and we too are pleased to be a part of this great event.
Absolutely. I should say that you're also a member of Cy Boulay of the Sigma Pi Phi fraternity, and
Yes,
very
I am.
prominently so, right?
Prominently so, thank you.
Okay, Now, for our panelists, Vivian Leslie Bibbs is the Director and Epidemiologist, Office of Health Equity, Kentucky Department for Public Health. The Office of Health Equity works to increase awareness, provide leadership and oversight on projects that address health disparities, including the social and ecological factors, and address system-level factors that impacts the health of disparate populations across the Commonwealth. She is the newly elected board chair for the Foundation for a Healthy Kentucky and current president for the president of the National Association of State Offices of Minority Health. We're also very pleased to have with us Dr. Mark Victor Burns, medical doctor, MD, assistant professor of medicine, Department of Internal Medicine, Division of Infectious Diseases at the University of Louisville School of Medicine. Dr. Burns is a fellow of the American College of Physicians, member of the American Thoracic Society, and the American College of Chest Physicians. He works with hospital epidemiologists in developing and assessing adherence to isolation procedures at the University of Louisville Hospital. We also have with us today Dr. Vicki P. Hines Martin, a PhD, is Director of Community Outreach, Office of Diversity and Inclusion, Health Sciences Center, University of Louisville, collaborates with the 4 Health Sciences Center schools, that's in dentistry, medicine, nursing, and public health, in the development of community projects, which include identifying community partners, collaboration on service, research and teaching project development, publication, and mentoring of students and junior faculty. And we also have Chief Executive Officer Delana Manson, CEO of the Kentucky Association of Nurses, and the principal in Manson Associates LLC, a health management consultancy. She is a senior level healthcare executive in quality and collaborative strategic planning, has more than 20 years experience providing executive management responsibility for operations, quality improvement, patient care, regulatory compliance, development, grant administration, facility planning, recruitment and retention, public relations, and business development functions in the healthcare industry and government sector. I might point out, she has served over 20 years in the United States Navy with a retirement at the rank of captain, managing complex healthcare in that arena and serving in 6 countries. So you see, we have a tremendous panel of experts here. And I want to welcome all of you all and thank you for coming today. So we will start with the panelists. We will start with Vivian Leslie Bibbs, if you will present at this time.
Thank you, Senator Neal. I wanted to thank the African American Initiative and yourself for inviting me to be a part of this panel. I feel honored to have been asked, and I'm hoping that I can contribute something to the conversation tonight that maybe you didn't know, and then leave you with some thought-provoking things as we move forward on how to help make sure that Kentucky is one of those leading states that's done due diligence for our marginalized and vulnerable populations. So I'd like to start out by kind of giving you where we are now with the numbers of vaccines that have been distributed into our marginalized and vulnerable and minority populations. I will say, as of today, these are the numbers. And I will preface that by saying there's some missing data. We don't capture race, ethnicity every time that we have vaccine put into arms. So we're working on that. As of to date, the data reflects 0.09% of Alaska Natives, 1.13% Asian, 4.33% African Americans have received vaccine to date, 0.07% non-Hispanic speaking or non-Pacific Islanders, 86.7% white, and 7.68% other. The other concerns me because that's a large number that we're not capturing. So we need to do a better job of that. And I know you're wondering, okay, 4.33% Black, what's the population of Kentucky, right? We make up almost 8.5% of the population. So there's some disparity there, right? We know that we could do a better job of making sure that we at least match that 8% with the 8.5 roughly percent of the African-American population in our state. At the beginning of the pandemic, we were seeing what around the country we're seeing. Black and brown communities were being impacted by COVID-19 at a greater rate than our white counterparts. We know the reasons behind that. Some of those reasons are the social determinants of health, where we live, where we work, where we play, right? Those social determinants, and even some of those upstream things that we don't think about, some of those systems, policies that are in place, the infrastructures that have been created that have disproportionately impacted people of color. So we started then saying, we want to make sure as we move forward that we are considering all of our populations and not just a few. So we've been moving forward now through the allocation phases of who receives the vaccine, and out of that conversation and recognizing those disparities, we formed the vaccine equity allocation work group and distribution work group. We've been working diligently to close that gap, to make sure that we are hearing the voices of our community, to making sure that we're being intentional, because I think that's what we have to recognize, that we have to be targeted, focused, and intentional in our efforts as we try to make sure that those that need the vaccine get the vaccine. So how are we going about doing that? Well, there's a number of things that we're looking at. We're looking at, of course, data, and there's a data tool called the Community Vulnerability Index that we're using. It is a validated database that CDC and the Sargo Foundation have put together to capture what's going on in high-risk vulnerable populations as it relates to housing, transportation, socioeconomic status, healthcare status, minority status and language spoken, and disability status. There are a number of factors that are rolled into this data portal that helps us look at census tracts. We are no longer looking at one size fits all. Let's just blanket a community with resources and funding and hope that we capture everybody. We really are intentional looking at the most vulnerable based on those themes, where they live. Are they a single dwelling, multi-housing dwelling? Are they a single family? What's the income of that family? Is there a healthcare system close to them? Do they have comorbidities? All of those things put people of color, right, at greatest risk, especially if we get COVID, that puts us at greatest risk for high mortality and morbidity. So we're using data tools to really give that information to our communities so they can do what they need to do to make sure that communities get vaccinated, either by them coming to a site or transportation being provided to take them to a site. So we're using data tools that we've never used before. This is a relatively new tool. It's been around a while, but new to us. And it's used to see the resilience of a community, right? How vulnerable are they and how resilient are they by the number of resources they have? The other thing we're doing is thinking of those non-traditional partners. We always think of the healthcare folks. We always think of some of our traditional community-based organizations. We think of our local health department, but we're trying to think of some of those other non-traditional avenues of communication, those non-traditional partners that are very instrumental in our communities of color. We're also looking at some of those traditional as well. We're trying to make sure that we're connecting people together to have those conversations. We want to know what's going on in communities. It's not fair for us, and I wouldn't dare try to say what's going on in a community if I'm not directly a part of that community. I hate the top-down approach. It should be the community speaking up to us, telling us what their needs are and how to best meet those. So we're making sure that we're putting people and resources and planning in place so we can assure that these communities are getting vaccinated. I think we need to recognize that vulnerable were those greater than 70 and are elderly. And we've got to remember that not only are they elderly, but we're not just confined to a race ethnicity group. We cross all of those. We cross essential workers, we cross our healthcare personnel, we cross our elderly, we cross all of those other areas, and to fit us in one box, I think is where sometimes we make a mistake. So I'm really excited about some of the work that's coming out of this group. We're connecting across cabinets, we're connecting across agencies, we're coming out of our silos, we're even sharing funding, which I'm sure some of you are probably wondering, shaking your head going, sharing funding. That's usually not heard of. We really want to keep our funding in our silos, but we really are trying to make sure that we're doing everything we can to ensure that this vaccine gets into Black and brown arms. And I can't say enough about the commitment from at least the Department of Public Health. And I can see that commitment even when the governor speaks, that he may not have all the answers, which is why I'm glad he's looking to us to provide him with some of that guidance and to give him some of those answers, that there's sincerity there, that he recognizes what needs to be done. May not understand how it all needs to be done, but I do believe that there's sincerity there on really making sure that all Kentuckians, right, receive this vaccine. So I'm going to stop there and see if Senator Neal has some questions for me, or if he'd rather know some additional information that I can share.
You're muted, Senator.
Thank you. We're going to come back and pick that up on the Q&A section. And thank you so very much. We'll be back with you. We now have Dr. Mark Burns, who will now give a presentation from his standpoint. What's important here is that he's an infectious disease doctor on the front line, and he can give us some insights into the issues surrounding that particular consideration as it relates to COVID. Dr. Burns.
Senator Neal and my esteemed panelists, thank you for allowing me to participate in this forum. Our present pandemic from COVID-19 has resulted in the largest physical and economic disaster of this century. Vaccines are now available, and it seems that there's a potential endpoint for this catastrophe. However, there appears to be reluctance among the minority community to take the COVID-19 vaccines. Reasons given for the reluctance include prior cruelty, including Henrietta Lacks and the procurement of her cancer cells without her consent, to the egregious and notorious act of the Tuskegee syphilis experiment. We in the medical community strongly recommend COVID-19 vaccinations, especially to the Black and brown communities. We do recognize that restoring confidence in vaccinations will take a concerted effort from the healthcare community to make amends. And we plan on doing this through transparent communication, ongoing conversations, and continued demonstrations of trustworthiness from the medical community to create a new narrative that will instill confidence in people that these vaccines are safe and effective. While healthcare and biomedical research institutions have a significant amount of work ahead to reduce health disparities and medical mistreatment of marginalized communities, we also want to ensure that we in the medical community are actively working to protect our members of our community from this current pandemic, and also to restore confidence in the medical community. Senator Neal, thank you very much, sir.
Well, thank you very much, Dr. Burns. We appreciate that presentation. We're going to come back with some Q&A as we've indicated before. Now we have Dr. Vicki Hines Martin. We would ask her now to share what information she will this time.
Thank you very much. I think what I'm going to do is kind of pull together what's previously been stated and then flip the script a little bit and talk about how the individual themselves, some of the things that might be impacting their perception of the current situation, how they think about COVID, how they think about the vaccine, and hopefully give some steps that can help people make decisions that have an understanding of the context in which we exist and how that can influence what we think, how we think, and what decisions we make. First, let me summarize what's just been said. African Americans and other minorities within the US compose a greater proportion of workers that are at the highest risk for COVID exposure, as much as 3 times more than others. They are essential workers or frontline workers in the healthcare, domestic, agriculture, and service industries, which are a huge number of individuals that we count on day to day, but they are risking their health and their lives as they do that service to us. Most of the workers are more likely to experience disparities in economic stability, housing, and other social and economic factors, which has previously been identified as social determinants of health. And therefore, they are more likely to experience the pre-existing conditions that make them more vulnerable to COVID and to have more severe responses, including death. So that's why this is important to talk about. Although Senator Neal didn't mention that, I'm a nurse. I'm a professor at the School of Nursing at the University of Louisville, and my role is to focus on community engagement and diversity and inclusion in everything that we do. So this is near and dear to my heart in terms of helping people not only to understand the individuals who seek health care, but also, because my area is mental health, helping people to think through exactly what they are considering and how those considerations impact their decision making and impact their comfort level with their circumstances and how they make decisions. So one of the things I primarily talk about are perceptions. Let me give you a definition of perception. Perception is the interpretation of an event or a situation based upon history. It can be a group's history, such as African American population and other minority populations, or it can be your individual history. It's about information and the beliefs that serve as the context each person uses to determine their actions and their decisions. So that means we could look at exactly the same thing and come up with totally different decision-making about what we should do with that same thing. So as long as people understand that all of those things are influential, it helps you to make better decisions about what is underlying how I see the COVID vaccine or how I see other protective measures. These factors, such as history, information, and beliefs, can act either as barriers or facilitators to how you feel about a decision or an action, especially in terms of health decisions. This particularly holds true with COVID-19, and that's why we're here to talk to you about that. Perceptions come from past history, collective history, and they can be multiple historical instances of racism, discrimination, and exclusion, which has previously been mentioned. They can be health and research victimization, such as Tuskegee, which has been mentioned, or health and research exploitation, as Henrietta Lacks, which has been previously mentioned. So all of these are building on what I'm going to try to ask you to think about as you hear this part of the presentation. They can also be present history and information, such as the current or just recent past political climate and the mistrust of the government. That certainly is an overarching factor that we need to consider. There's also experiencing poor or discriminatory treatment as an individual or as someone in your family has experienced, or the lack of any healthcare access or uncertain healthcare access. Significant disbelief in COVID as a reality is common. We don't want to think it's common, but it is. There's also mistrust in science based on very valid past inequity and exploitation. So I am not saying any of this is invalid. I am saying those are the things that come into play to decision making, especially when supported by other trusted individuals. So if you're someone you trust in your family says, oh, COVID's a hoax, if someone within your professional social circle says that, or if they have a religious perspective that says, maybe we shouldn't trust this. All of those things are particularly influential. Beliefs about the limitations of your ability to manage your health, sort through all the information, and make decisions for you or your family's health are influenced by this mountain of things that I just talked about that influence your perception, in addition to anything else you might be dealing with were COVID not there. This results in feelings of uncertainty, worry, anxiety, fear, and sometimes powerlessness to do any action. That's not a weakness. That is something that many of us commonly feel at some point or another. What we have to do is figure out to move past that if we can. So how you feel is directly tied to your perception of this very extraordinary circumstance on top of everything else. So what do we do with that? Well, what we do is, I hope we get a better appreciation of the very valid concerns that result in fewer members of diverse populations say they will definitely get the vaccine as soon as possible. That's much lower than those from the majority population. In a recent Kaiser study, they identified that only 35% of Blacks said, I'm definitely getting the shot. 42% of Hispanic and Latino populations, 47% of urban populations, 42% of rural populations. And you think politics has nothing to do with it? We all know it does. 64% of Democrats say they're definitely going to get it, and 32% of Republicans say, I'm definitely going to get it. That's a huge discrepancy. So all of those things layer on top of just the fears or the hesitancy based upon how you've been treated in the past within the healthcare system. The largest group of Black Americans take the wait and see approach, and that's 43%. So let's start with those first. How do we move the needle on people who are open to moving the needle? Others may come along as they see things are not as difficult or harmful as they think they are. But everybody needs to look at information. And that information is what, where, when, who, how, and what can. So what can I do? Where can I get the needed resources or help? When will things happen? Who can I contact, seek counsel from? Can I trust? Is at risk? How do I protect myself? Do I talk with others? How can I get my questions answered without feeling embarrassed or pressured? Everybody in the room wanted to know that at some point in time. And if you are not aware, everybody that's speaking on this panel has taken the vaccine. So we are speaking from a point of being transparent of what we've done and hopefully being an exemplar of how it works. First, step one, acknowledge that there are real reasons you feel as you do. Give yourself credit. You've made changes already as a result of COVID, such as masking, distancing when you can, and attending this panel. In the past, you've taken vaccine, or your child may have taken vaccines because of the care you have for them and others around you, and you're still standing. Congratulate yourself. Find those like you who have been part of the science that resulted in vaccines. Dr. Kizzmekia Corbett is an African-American woman scientist that led the NIH team in the co-development of the Moderna vaccine. She's given an extreme amount of credit. You may or may not know her. She was a student from the South who took part in a program that supported minority students in the sciences, and now she's using that science to the benefit of us and everyone else. Dr. Marcela Nunez Smith is an African-American Latinx physician, the first ever advisor leading the Health Equity Task Force on COVID-19. She was focused on health equity for 20 years before she ever came into this role. So she was invested in this. But also the people who are participating on this panel. We are all committed to the health of our community, all for a number of years. We come with credentials to let you see, not only do we know our subject matter, we care deeply about our community, and we hope you can see that. Step 3, expect transparency in terms of making public the impact of COVID on various populations, evaluating the vaccine, and having those who have taken the vaccine to give realistic presentations of what it's like to take it. Let us know, what kind of side effects, so people can say they're not just presenting a rosy picture, they're presenting a realistic picture. And know where to get reliable information. I have forwarded a list of reliable information sources, both locally and nationally, for a variety of populations. And I believe that'll be made available to people in the chat. And then lastly, talk with others in your circle. Expect some hesitancy from others. Change and feeling safe about a decision to take healthcare steps needed to protect you and those around you against COVID is a process. The small steps toward addressing your perceptions and examining the possible decisions to take the vaccine are important. I hope we can help you through listening to what the panel has to say and answering your questions. Thank you.
Thank you very much. I very much appreciate that presentation. And now we have Delana Manson. There's something that goes through everything that I've heard so far, and that's that issue of trust in terms of the reluctance of the portions of African American community to participate. But also, I noticed, or it's been reported, that there are individuals such as healthcare professionals that some of them have not taken part in the vaccination process. Delana, could you give us some insight in that as you give your presentation, if you will? You're on mute.
Absolutely. Senator Neal, thank you so much for inviting me to participate. I'd like to start off with the trust issue. I think I heard that from every single person, and specifically from Dr. Hines Martin. We talk about that a lot in our conversations. And the reason I want to start with the trust issue is I am a nurse as well. And nurses have been identified as the most trusted profession for 19 years in a row by the Gallup poll. And to those who much has been given, much is expected. And I want to go through the much has been expected with the nurses. In 2020, that was the year of the nurse. And since we had a pandemic and we really didn't get to honor nurses the way we wanted to, we're going to claim 2021 as well. And the Kentucky Nurses Association spent a great deal of time focusing on mental health early in the pandemic. Dr. Hines Martin and a co-director developed a program called Kentucky Nurses Helping Nurses. We had 110 nurses from around the state who volunteered to speak with nurses who are on the front lines 24/7 and who are continuously in harm's way. We will also speak with physicians if they call us, or any healthcare provider who is on the front lines. We also develop some programs, some webinars, and we have a web page for people to learn how to do short take care of me sessions. We developed a sign for nurses that said, "Thank you, nurses." We distributed 475 statewide. We had about 70 volunteers who drove 7,000 miles to make those distributions to every hospital in the state. Many of the nursing homes and many homes have it in the front yard. We did an apricot ribbon campaign to say to nurses, and apricot is the color for academic nursing, you are appreciated, you are seen, we want you to know that you are not alone. Because nurses are so trusted, we also wanted to make sure that nurses had the latest and the greatest on COVID, as well as COVID vaccines. We provided 27 classes for the nurses because we know that people are going to ask nurses, what should I do? They're going to ask them questions about, what about this vaccine? Has it been rolled out too fast? Can you give me the specifics on that? And because things are changing on a day-to-day basis and what we're learning, because it is a new disease, a new virus, we wanted nurses to know what the answers should be. We worked with the University of Louisville School of Engineering, Speed School. They made face shields for us. They made 1,000 of them, and Ford Motor gave us 1,100 face shields, and we delivered those around the state. We took contributions from the distillers around the state, the bourbon distillers. They gave us 345 gallons of hand sanitizer, and this was during the time when you couldn't buy hand sanitizer in the store. It was all gone. We used a machine from Southeast Christian Church. It's the machine that they use to fill their communion cups. They let us use their machine so that we could fill hand sanitizer bottles. That the hand sanitizer was made as a derivative from the bourbon distillers. And I thought that was kind of interesting, from the church, from the distillers to the nurses, and we got it all done. We filled 14,000 bottles of hand sanitizer and delivered those around the state. We started with asking volunteers to come and help us, because we knew that we as nurses were going to be on the front lines, and we needed to help other nurses through the Kentucky Nurses Association. We started a GoFundMe fund. We raised about $19,000 so that we could buy the bottles and pay for the signs and the ribbons and get them out. What we've been doing recently that Senator Neal wanted me to talk about is our participation as volunteers. We've been supporting the nursing schools by arranging for nursing students to participate in testing and vaccinations, because they haven't been able to get their clinical rotations in hospitals and other clinics. So far, we've placed about 600 students so that they can get a clinical experience, so that when I get older, they'll know what to do for an older Black woman, you know. And so we've also helped with the design for the broadband. That's where we're doing the LUVAX, the drive-through vaccination clinic. We have over 5,000 people who are helping out there. Many of those are nurses or volunteers from the Kentucky Nurses Association. But what I'd like to talk about a little bit is testing. Our testing is down about 30%. And we really need to encourage the community not only to get the vaccination, but to continue with the testing. And I'm sure many people will say, well, why do we need to test when we have the vaccine? Well, first of all, and I know that we're going to get to that in the question component. If you go to the grocery store and you encounter other people, there's a possibility that you can get COVID. And so you need to be tested. And there's no fee for testing. And the testing, there's lots of rapid testing now. So you don't have to do the through the nose and down to almost the throat, what we call the PCR. So there's opportunity for you to get tested that is not painful, is what I'm saying. So I want to encourage people to think about what Dr. Burns and Vivian talked about and Dr. Hines Martin, because we understand that you have questions, and we're here today to help to answer some of those questions. So let her rip, give us the questions.
Well, thank you so very much, Dylan. I appreciate that presentation. We should keep in mind that we're simulcasting this event on WLOU Radio 1350 on your dial. I would like to start with a question with you, but before and right after that, I want to get to my co-moderator, because he has specific expertise himself. And I think we have the unique opportunity to hear from him to add a layer of understanding and education to this process. But I do want to ask you a question real quick. How can, you mentioned something about a website. What is that web? How do they get access to that web? Dylan? Are
you speaking about the website for mental health support?
Yes, I believe you made reference to that.
Yeah, it's the Kentucky Nurses Helping Nurses program. And if you go to the Kentucky Nurses Association website, it's kentucky-nurses.org, and click on Kentucky Nurses Helping Nurses. You can get to the website, and there are a host of materials that you can use, videos that you can see, resources for you to help with supporting mental health.
Thank you so very much. So what we're going to do is we're going to get into a discussion about various of the issues, and of course I will contribute to the moderating aspect, but I want to get to my special co-moderator, Dr. Lewis Hargett, because I would ask him to give some insights. He has a special area of medicine that he practices, and has a very special perspective on this. And I wish he would expose that to us at this time, if you will, Dr. Arkin.
Thank you, Senator Neal. First, I'd just like to comment on the physician aspect of what physicians across Kentucky are doing in regards to educating people about the COVID-19. And we got the Kentucky Medical Association, which is very active, the Jefferson County Medical Society, which I'm secretary, as well as the Falls City Medical Society, which I'm president, and it's the African American Medical Society here in Louisville. And so the KMA, Jefferson County, as well as Falls City, we are constantly updating information and getting that information out. In regards to Jefferson County, since we live here in Louisville, we are focused obviously on Louisville more so. And we've done various op-eds, we've done various educational pieces. Our own Dr. Burns here is on the mayor's task force for the rollout of the vaccine. And so we're constantly updating information on the virus itself. And I also would encourage that the Public Health Department, Louisville Metro Public Health, has a website that you can go on and you can get the latest, most up-to-date information on the virus, where the testing is being done, where the vaccines are being done, in conjunction with the local television and radio stations as they put this information out. As you know, this is a very fluid event, so data is being constantly updated and put out. So you have various places that you can go to find out what's going on with COVID, where you can get testing, where you can get vaccinated, and that type thing. In regards to my specialty, I'm a physical medicine rehabilitation specialist practicing here in Louisville, primarily at Kentucky One. Well, actually, it's University of Louisville, a Jewish Hospital, Fraser Rehab Center. I see the worst of the worst COVID patients. And as you all know, COVID has been going on for quite a while. And at the start, you know, the knowledge about COVID was new. The treatment about COVID was new. And we, you know, lost a lot of patients, but the patients that survived, who've been in the hospitals for several weeks, even months, those are the patients that I take care of. Jewish and Kentucky One has a COVID unit like most hospitals. Fraser used to have a COVID unit, now we have a COVID section. And so I get those patients that have been severely deconditioned, very weak, sick for months on end, on a respirator, almost died. And so my goal with the rehab team is to get these patients back on their feet. And so patients that have been in the hospital, as I mentioned, months on end, weeks on end, we get them, we rehabilitate them, physical occupational therapy, continued medical care is indicated to work at getting them back home. And so with that, if it's okay with you, Senator Neal, I'd like to start the questions off. I have a question I'd like to direct to Dr. Burns.
By all means.
And that would be, Dr. Burns, if you could just let the people who are streaming know exactly what coronavirus is, because a lot of people still don't understand what is coronavirus. I get asked that question myself. Really, what is it? So if you could just tell them exactly what coronavirus is.
Well, the coronavirus is an RNA virus. There have been several coronaviruses discovered. As a matter of fact, there are like 4 human coronaviruses that were first discovered in the 1960s. And throughout the decades, others have been discovered. We have 4 human coronaviruses. This particular coronavirus, SARS-CoV-2, it's a unique type of coronavirus in that it is part human components, but also has had part animal components. And what I mean by that is the virus is believed to have had a reservoir in bats. And we're not exactly sure how we got what's called a crossover from the, let's say, from animals to humans. But presently, there is a team in Wuhan, China, where this particular coronavirus, SARS-CoV-2, began, and they're actually doing investigations of that. And just to also give you just a real brief historical background, there have been other types of coronaviruses of this nature, that is part human, part animal. The very first one was the SARS-CoV virus, severe acute respiratory syndrome virus that was first discovered around 2004. The second one was called MERS, and that's Middle Eastern Respiratory Distress Syndrome. That was a coronavirus. That was actually discovered in the Middle East, with the reservoir being in camels. So as I said, this particular one, we know the reservoir. Reservoir was primarily bats. But right now, research is still ongoing to try to help determine how we got a crossover from that species into ours.
Let me ask you something. I think folks would like to know. They're not just talking about the coronavirus as we heard it several months ago. Now they're talking about mutations of the coronavirus. They call it variants. I know that there are 3 different places where they have identified that they've emerged: UK, South Africa, and Brazil. But the question as to these variants, what relationship or what is the impact of the vaccine on the variants? Is that clear yet? Or any one of you that have that information? I would think Doc Burns, perhaps.
Well, I'll be happy to start out. First of all, remember we're talking about viruses, and this particular RNA virus, this virus tends to mutate. That's what all viruses do. They do it primarily as a means of survival. So by mutating, what I mean is that it takes its, as it's reproducing with its RNA, it has bases that are in there that cause the virus to mutate, cause the particles or for it to reproduce. I won't get too heavy into the science, but suffice it to say that sometimes when they mutate, they tend to make, when they replicate, they have a tendency to make mistakes. And when they make mistakes, whether it be accidental or on purpose, that's when you get what's called a mutation. Now, as I indicated, viruses tend to mutate to survive. And with regards to the vaccines that we have now, the Pfizer and the Moderna vaccine, they were primarily targeted against the, for lack of a better term, original coronavirus, or what we refer to as the wild type coronavirus, before the mutation. When you hear about efficacy of those viruses being 94 and 95% respectively, that was based on the fact that it was tested against this wild type virus. The good news for right now is that despite being mutations or variants, our present vaccines do still cover or treat those mutations. Now, the efficacy is down some, more likely in a range of 70, 75%, but still effective. Mm-hmm. And so that's how it relates to these variants. So that's why it's sort of important. I know we'll get into this later, but it's really important when it comes to vaccines and vaccinations and getting people vaccinated, because by getting people vaccinated, the virus won't have any place to go and to mutate. Yes. And I believe our epidemiologists will speak to that. And without replication, it won't mutate.
Dr. Hargett, do you have a question at this point?
Yes, I just want to put a question out. I get asked these questions. I want to put it out to the panel. If you have your COVID shot and you've had your booster, what can you do or what can't you do? Can you go out with crowds? Can you, in other words, what do you recommend as epidemiologist or from that standpoint to the general public? Should they go to social gatherings? Should they should they wear their mask? Just give an overview of what to do once you've had your COVID shot.
Sure. So what I'm trying to get people to recognize is that when you get the vaccine, you still have to practice those guidelines that CDC has put out with your face mask, your social distancing, your hand washing. You're not forming antibodies after that first dose, 2 to 3 weeks to form those antibodies. That second dose, you don't reach maximum protection until after that second dose. People are like, "Oh, the first dose, I'm good. I can do anything I want to do now." That's not the case. And I was just listening to the director of CDC this morning talk about 3 months out, and I'm not sure if anyone else heard that after 90 days, they consider you to be as protected as you would as if you'd had the flu vaccine or some other. So I don't want to, if someone else has heard something different, you can correct me. That's what I heard her say this morning. So I want people to recognize that even though you get the first dose, I have a physician in Lexington who had his first dose and contracted the virus and was very sick, but recovered and got his second dose and is now doing fine. I also had a physician friend in Nashville who had her first dose, contracted the virus, was put on a ventilator, and within 5 days she was gone. So I've lost personal friends because people are feeling that they're very confident that once they get that vaccine, they don't have to do anything else. And I think we need to work hard with that messaging to let them know that that's not the case. So,
Dr. Hans Martin, let me ask you, you went in depth about some of the reasons why people, African Americans in this particular instance, are reluctant to take that. Could you go deeper into that? Because I've talked to some people, quite frankly, that basically are leaning more toward, instead of the fear of somebody trying to trick them, they don't have confidence in the vaccine. They want to wait and see. That seems to be a very prevalent perspective. Is that what you're finding?
That's what I'm finding, but that's also what the research is showing. There's a very small percentage of people say, "I'm not going to take it at all." That's very small. Whether it's small or not, it's something we have to deal with. But the vast majority who have not said, "I'm definitely going to take it as fast as I can get it," have said, "I'm going to wait to see." And when asked what they're waiting for, they want to see how well is this going to work? What are the potential side effects or negative consequences of it? And do they still have that feeling that they don't have the confidence in the science or in how that's going to work? So they want to see what happens to other people first.
Senator Neal, I'd like to address that. Dr. Burns and I were on another panel discussion. And Dr. Burns, you can fill in as I go, if you like. And we were with another epidemiologist, and it wasn't you, Vivian, and I'm sorry. You would have been better on there. No, she was good. She was good. I'm sorry. But anyway, she talked about being in the Moderna trial. Do you remember, Dr. Burns? And that she got her first dose in March of 2020. And as she sat there to tell us how good she felt, and that she had participated in the trial, and her motivation for participating in the trial was that she wanted to make sure that it would work well with African Americans and Black people. And so, she's a year out. So she's a good example, but most people don't know about those people who are a year out. And I also want to remind people, as Dr. Burns mentioned, that this type of vaccine isn't new. In 1996, Bill Clinton established the Vaccine Research Department. Now, 1996, people. So, and they've been working on vaccines and the mRNA, using that as a basis. The flu, HIV, Ebola. So that's the same type of vaccine development. Dr. Burns, do you want to expound on that a little bit?
Yes, because of those uh, earlier coronaviruses that I mentioned, SARS and the MERS. As Nurse Manson indicates, yes, they were developing vaccines at that time, and particularly using the mRNA platform. And it just so happened that when SARS-CoV-2 became, I guess, known and prominent, and after we knew the genetic makeup of it, which was actually published by China shortly after discovering the virus, we were able to immediately begin working on the vaccine. So we really sort of had a head start with the other two coronaviruses.
And I'm so glad you all brought that out, because I'm getting questions in my office. This is new technology. I'm not going to take it. Nobody knows what this, that's not the case. So I'm so glad you brought that up. And I just wanted to go back to something either Dr. Hines Martin said or Delano, I can't remember, about the vaccine hesitancy piece and people thinking that, you know, they're going to wait and see. We were seeing that when we first rolled out the vaccine in our long-term care health facilities, because a lot of those frontline workers were of color. A lot of those frontline health workers were like, no, I'm not going to take it. I'm going to wait and see. So we had to kind of catch those persons that decided, okay, I've seen it. My counterpart didn't get sick. She's okay. I'll take it now. So we had to make sure that we had enough doses to go back in and catch those people that said they were going to wait and see. So I'm glad both of those points.
I've got a question I want to ask that, again, maybe Dr. Burns, you can answer this too, is that patients have asked, well, I've had COVID. Why do I need the shot? What's your thoughts on
Maybe
that?
I could do that with you.
Okay, well, it is true that a person that has had COVID-19, they will develop antibodies to that, to the COVID-19. The problem, however, becomes we don't know how long those antibodies will last. Right now, it's projected that those antibodies will likely last for about 3 months. It's been shown with vaccines that will induce antibodies. Those antibodies will last longer. Now, again, we're not sure exactly how long, but it definitely will last longer. The other interesting piece, or the wild card piece to this, as we had talked very briefly before about the variants, and what is true and what is known now by recent studies, that the people who have previously had COVID-19 and developed antibodies, when it comes to exposure to one of these variants, the B117, which is the UK variant, or the B1351, which is the South African variant, and even the Brazilian variant, which is also known as P1. When they have come in contact or exposed to these variants, their antibodies that they previously developed from that previous COVID-19 infection will not protect them against these variants.
Yeah, I mentioned that because I had a patient that just went home from Fraser, who got COVID in November. And so she went home. That tells you how long she had it. And she was asking me, she said, doctor, do I need to get set up for my COVID shot? I said, yes, you do. Yes, you do. Mm-hmm. And I'd also want to ask a question too, in regards to quarantine. As you know, we're getting more and more people vaccinated and that type thing, more and more people who've had COVID. What's the latest information on quarantine if you're exposed or if you've had COVID vaccine?
Okay, well, the latest information from the CDC, and I believe this is what Dr. Bibbs was alluding to. The latest information is that a person who has been fully vaccinated, both shots, and it's been at least 14 days, 2 weeks since they've had their second shot, that at this point, if they are exposed to someone who has COVID-19, they do not have to quarantine. And that's that's what the latest science shows us at this time.
And Dr. Burns, when you say the latest, it's been in the last week, correct? That they came out with that from the CDC. Am I right,
That
Vivian?
is, as a matter of fact, I believe it was last Thursday or
I
Friday.
was
Last
going to say
Thursday.
it's hadn't been a week. It's about a week.
So it's been a
Changes.
week. Yeah.
You know, it just struck me just listening to this conversation, and we're talking about the question of trust. You have to keep in mind this thing is evolving on all fronts, and there's so many things that you're gaining knowledge about. I'm talking about the experts are gaining knowledge. I guess Dr. Hans Martin, I'm assuming that's an underlying issue there, of the uncertainty, because there's information that the experts admit is not available.
That's true. And sometimes that's exactly what people say. Well, first you told me this, and now you tell me that. And
Yeah.
it appears as if you don't know what you're talking about, when in fact, as you gain new knowledge, you are better able to respond to those kinds of situations, give better advice, instruction. So I think framing it from that perspective, as we know more, we tell you more,
So
rather than we don't know what you're talking about.
So Dr. Burns, so if you don't know just what she just said and you worry about it because you know you don't have that information, why should they trust getting a vaccine?
Okay, well, again, this goes back to the transparency and trustworthiness,
Mhm.
particularly with your physician or someone who's an expert in the field. And as someone who's gotten the COVID vaccine, fully vaccinated, there are things that I can attest to just from my experience. People should continue to understand that this is a very fluid situation, such that it changes rapidly, literally from day to day.
Mhm.
And so we're still learning things about this as well. But as we learn and as the science proves out, then we try to make known. And this is also bore out in what's written at the CDC with their latest findings on the science.
So I'm going to ask Alan to come on and ask some of the questions that have come on either chat or the radio station, and just a couple questions, and then we'll go back to Dr. Hargett, if we will.
Hello, given that the COVID-19 has affected many minorities disproportionately, and there's been additional information out in terms of we should now wear a double mask to improve the protection, are there any extra steps that you feel that the minority community should take in terms of being better protected, as well as gaining better access to the vaccine?
I can address the double mask issue. I can pretty much tell you. The CDC standpoint is that they either prefer, if you're going to wear a cloth mask, it has to be at least 2 to 3 layers thick. What's ideal, however, and what's also recommended is a surgical mask to help filter, and a cloth mask on top of that to help the fit better over the nose and mouth, which I know Nurse Manson will also endorse that people need to wear masks correctly. And we can't tell you how many times, even on television, you see people with masks under their noses, especially, which is no good, or above their chin and things like that. So the masks have to be worn correctly. But the other thing too is that the mask has to be breathable.
Right.
So double masking, especially in face of these new variants that are much more contagious, much more virulent, is extremely helpful. But one last thing I wanted to say, in addition to that, we should continue, as a matter of fact, we should double down, if you will, on our public health mitigating measures. The usual things you hear: wearing masks, wash your hands, social distancing, staying away from crowds. In addition, and as Delano Manson also mentioned about testing, getting tested. And by the way, just also to mention that the FDA has approved home tests now that can be done for COVID-19.
I just wanted to add something related to those additional measures. Some of the things that I'm seeing personal friends do and hearing from my colleagues is that we take the concept of social distancing, meaning when I go out, not really when people come into your space. So, we are a very social people. We are very, we want all our family to come by. We want everybody to still visit. We want that social interaction. That connectedness is important to us as a culture. But you got to understand, when people come into your space, they should be masked. If they're coming into your home and you don't know where they've been or who they've been exposed to, they have to wear a mask when they come into your personal space. And if they don't, then you should. So there's some things I think that we still need to get people to understand about what that means, what the social distancing and respect of space means. It just doesn't mean when you go out somewhere. It means your own personal space, where you live, where where you work, all of that. So I think we need to reinforce that messaging as well. So,
Alan?
Okay, second question is, what will the new normal look, or what will normal look for this society? Will there, for example, include being vaccinated annually, or what are you all's medical opinions of that, or estimations?
start that one if you want to, Dr. Burns, and I can punt to you after that, if that's okay.
Certainly, certainly.
Okay, I hate the term new normal. So if I can kind of speak to because I think in communities of color, the normal for us wasn't good from the beginning. So to tell us to return to a new normal is, to me, very condescending. To think that we want to go back to what we had before. We ought to want to be going back to something better. So I just wanted to make sure that I kind of prefaced you with that, Dr. Burns, and then you can go on from there, because that's one of my pets.
I love it.
Yeah, certainly, certainly. It's really hard to say right now. I would project that before we could, let's say, get away from masks and social distancing, before we get away from that, our numbers, our infection numbers, have to come down dramatically. I'm talking about pre-April levels, April 2020 levels.
2020, right.
One thing that's really interesting is that when it comes to other infections such as the flu, influenza, and common colds or respiratory syncytial virus, those things are markedly down. And this obviously is as a result of our public health mitigating measures that we are doing primarily for COVID-19. But this has sort of been a good side effect of this. But with regards to the quote unquote new normal, it's really hard to say at this point. My feeling is that even when the numbers come down, even when, let's say, businesses open up back to the normal capacities and people are able to resume their social lives prior to COVID-19, I suspect there still will be people wearing masks and hopefully washing hands and hopefully, to a degree, at least distancing, at least from people that they don't normally come in contact with. So that's my vision of what the quote unquote new normal would likely be.
Dr. Hargett?
I tell people that ask me about what do you foresee as the new normal, I just tell them, I say, well, let's wait and see. I said, one thing I'm sure though, we're not going to see people shaking hands like they used to. We're not going to see people hugging, when they see each other like they used to. But I think that once we get mass vaccinations, as Dr. Fauci said, get herd immunity, people can let their guard down some. But going back to the old normals of greeting people, shaking their hands, hugging people, every time you see them, when you meet them, when you leave them, that type thing, I see people are going to be a lot more reserved to doing that, particularly during the wintertime as wintertime comes. But I see it in general. But as a whole, I tell everybody, let's just wait and see. But let's get people vaccinated. Let's get this coronavirus taken care of. And then I tell everybody, let's just wait and see.
So what's the herd immunity? I've heard several things about that. And somebody, please clarify, what is herd immunity? What do you have to get at in terms of I guess, vaccination or infection rates or whatever that would suggest that we've got a handle on this COVID virus?
Dr. Burns, I'll let you handle that.
Well, actually, we do have an epidemiologist here.
Oh, I didn't
Go
find
ahead.
out earlier.
And-
You can go ahead. You can go ahead, Dr. Burns.
Okay, well, in essence, when we talk about herd immunity, we're talking about when we have enough people vaccinated such that infection rates are low and the virus essentially has no place to go and replicate. According to the WHO, they really don't have a number for herd immunity yet. Dr. Fauci does mention.
He does have, yeah.
Yeah, Dr. Fauci mentions anywhere from 70 to 85%.
80%, yeah.
Of people getting vaccinated. That is talking about the entire population before we do achieve this herd immunity. That is enough immunity such that that in this particular case, the coronavirus infection won't have places to go to replicate and mutate, and thus will hopefully become obsolete. Hopefully.
So I guess that raises the question about our responsibility to each other. If you're going to get herd immunity, and that's what we need to defeat this virus, then everyone's in the equation, correct?
Right, we need everyone to get vaccinated, absolutely.
So where do they go to get vaccinated? We're in Kentucky. I know every state has its own challenges, and I know we just went through a questionable run before we now have the focus of the federal government on this. Is it different? Is it changed? Where can people go now? What can they count on in terms of getting access to the vaccine?
I'd like to start off by saying that Dr. Burns and I both are on the COVID task force for Jefferson County. It's the mayor's task force. And it started in January. And I want to say that one of the first things we looked at was, how do we vaccinate our Black and Brown community? How do we roll out the vaccine to those communities that have been marginalized? How do we roll out the vaccine to communities who have shorter lifespan? And the planning started then. So where do you go? Well, we have been doing out at Broadbent and Luvax, and it is a model for the country. We have people all over the United States calling to say, can you help us set up a drive-through COVID vaccination clinic?
Describe that location you just said for the listeners.
Oh, the Broadbent Arena out at the fairgrounds. We have set it up so that we have 3 shifts a day. We have about 120 volunteers every day. And they do everything from checking people in, making sure that they have an appointment, taking their temperatures, helping them with the paperwork. They get their vaccine there. They're monitored afterwards to make sure that they don't have a reaction. And we also are doing education as they go through. We also have some walk-in ability. The Jefferson County Public School System has been putting teachers on buses and bringing them out in, I think it's a bus an hour, and we've been getting them vaccinated. So when we first started out, we started out slowly because we wanted to make sure that we had everything in place, including how we drew up the vaccine, making sure that our hoods were working properly. We did 1,000 on the first week. On Friday, we did 2,100 vaccines on Friday. So basically this drive-through Luvax center that is a model for the country is doing very well. In fact, I think we can vaccinate up to 3,000. If we can get the vaccine, we can vaccinate 3,000 a day.
Which raises
And I think you hit on the head the amount of the vaccine that you can get. It's the allocation issue.
That's the major issue.
That's the major issue.
Well, let's get into that. Talk a little bit about that. And I'm going to toss it over to Doc Hargett, but talk about that allocation issue, the availability of vaccine. What can we expect? I know there's been a ramping up on the federal level. And I do want to get back to Dr. Hans Martin, because I know she's got an answer as to how we're going to get people to come in and overcome their reluctance. So I'm setting her up for that one.
Vivian, did you want to talk about the vaccine distribution? Because I'm
Yeah.
sure you have the latest since Friday.
Right. Yeah. Yeah, and I think it's even changed today. So,
Man.
Yeah. So as of today, I know you may or may not have heard that those that are at our daycare centers and our early childhood centers are going to be the next group to be incorporated into that
No, I hadn't heard that.
category. So that's, we're excited about that group wanting to be vaccinated, but the issue arises of allocation of the number of doses that we have. So I think people need to, when they hear that vaccine is here and they hear that we have vaccine in Kentucky, they don't recognize the fact that what we were allocated originally by the federal government, that number dwindled drastically when it finally reached the state. And we had to go through algorithms again to reallocate those doses as to who they went into first, which we all know were the essential healthcare workers and frontline workers and EMS, EMT, all of those essential folks. And then we had to make sure that we had allocations enough for that second dose to ensure that, we had everybody covered. And then, like I said, some programs we had to go back in and revaccinate. So there's always been this issue of how much we have for the number of people that we want to make sure that are vaccinated. So I think that's important for people to recognize. Now, having said that, there are programs now that we're looking at. Independent pharmacies are now getting monies from the feds to roll out vaccine in rural and urban communities that don't have any other mechanism, right? Or either a rural health center or an FQHC or any other clinic to get that vaccine into communities. So now we're looking at these local independent pharmacies that are a part of this conglomerate, and I forget the acronym, Amera Sortsbergen, who is the conglomerate that is controlled of all of these local and independent pharmacies. So that's going to be something now that we're looking at, extra vaccine coming into those communities via that mechanism. Additional sites being put up, as you've heard, with Kroger and Walmart. Some of these other entities are going to be getting vaccine as well. So as we get the vaccine, we're constantly redistributing the numbers and running the algorithms again and recalculating to make sure that we can get the most vaccine into those communities that need it. But it's a challenge. It really is, because you want to give more to certain communities. And I will say that we've been given that flexibility as of last week to say if local health departments have vaccine and they recognize a marginal and vulnerable population, don't wait. Give it to them now. Don't wait till they fall into the category. If you know you have them, you have vaccine in your possession, and you can make sure that they get their first and second dose. Give it to them, which it was very rewarding to hear that they're not restricting us to those stringent categories. So that's all I wanted to say, Delano.
Oh, I'm sorry, Delano.
Well, I just wanted to dovetail on Vivian, is that in Jefferson County, we did something I think was pretty creative, but it didn't happen overnight. And that's the other thing that Vivian is talking about, is that none of this planning and execution happens overnight. We rolled out, there were 2 vaccine clinics, one at St. Stephen's and one at Bates Memorial Baptist Church I think it was Thursday and Saturday. And then there has been access to vaccines at the Y, the Norton downtown. So these things have been planned so that they can be executed. But the amount of vaccine that we get is the constant. For instance, if we were to get, 20,000 doses, out of that 20,000 doses, we still need to allocate to those marginalized populations. And so we don't get any extra for those populations. So when we talk about those algorithms of how we're going to get that out, that's part of that consideration. It's a finite amount of vaccine.
Senator Neal, one other thing I want to add just to that, onto that, just so everybody understands that when it comes to the vaccine, they here in Kentucky anyway, and I'm sure this is pretty much the same way everywhere else, not all over the U.S. It's been rolled out and being given in phases.
Yes.
Yeah, you got phase, the very first one that people, when they first came out, they saw was getting to healthcare personnel and people in assisted living and long-term facilities. We since then went down to that's the 1A, the 1A
That's
level.
1A.
1B was next with the first responders. It went over 70. And for us, I thought this was interesting. The school teachers, K through 12,
Yes.
were being vaccinated. So I'm sure Dr. Bibbs appreciates that. We're going into, I believe, 1C now, which
Yes.
is anyone over 60 or anyone age 16 and older with comorbid conditions, along with all essential workers. So
Comorbid meaning?
yes, things that would portend a very poor prognosis. For example, somebody that may have sickle cell disease, diabetes, hypertension, kidney disease, chronic long-term diseases, basically. So that's where I believe that's where we're going into now, the 1C.
We're in one, yeah, we're headed into 1C. Yeah.
Doc Hargett.
Yes, I have two questions that I want to put out to the group to discuss. And that's one we hadn't talked about, and that's children. As we all know that children do get COVID. And do you have any numbers on African-American minority children getting COVID and, the treatment for that? And when is COVID, when should parents be aware that it's concerned about COVID versus flu or that type thing?
I can address the numbers issue. No, we don't have any, we don't publish that data. And I'm sure we capture it through our VFC providers, which is our vaccine physicians that are part of the vaccine program through the state, but we don't report that information out as we're marching through COVID now, through the pandemic, because of the vaccine only being eligible for those that are 16 and older for one, I think, 18 and older for the other. Correct me if I'm wrong, or are they both 18? I think one's 16 and one's 18.
One's 18.
Yes. Okay. So that's the only age group that we are concerned about at this time. And I hate to say that, but we're not looking at children under those ages. So,
but there's a reason for that, and that's and when they did the trials, they didn't have a large number of the children in the trials. And so they don't have the data to say that this, there's no data to say that it's okay for the children at this point. Did I do okay, Vivian?
yeah. I think there's one other thing we need to recognize too. When people tell me, Vivian, how can this vaccine be effective if there were not enough African Americans taking part in the clinical trials? And my answer back to them is we have to participate in clinical trials. I mean, if you want the numbers to show how they actually, if you want to increase our numbers in participating in these clinical trials to feel more confident in what's being seen in Black and brown people in these trials, we have to participate. So I think some of that they throw back, well, that's not a large enough number. They didn't have enough of us represented in the trial. Well, you can argue that, both ways. Yes, they.
You're muted.
Oh, sorry. Yeah. To make sure they went through all the calculations to make sure that they had a number that would be significant. But at the same time, we have to be diligent on our end too, to participate in those clinical trials. So when I see the African-American folks that come on the webinars and say, I participated in the clinical trial.
I did.
There you go. There you go.
I did.
Well, Dr. Hargett, go ahead.
Yeah, I was going to ask, another big concern that patients often ask you about is side effects. And, you get the shot and you have to wait 15, 20, 30 minutes, to make sure you don't have a reaction. Would anybody like to expound on that as to side effects of getting this COVID shot? And what are the latest statistics in regards to side effects and what's most commonly seen?
Well, I can talk real briefly. When we talk about the so-called side effects, that is, if people get the vaccine, let's say, for example, they might get maybe a headache, maybe a little muscle aches, feel like they have flu-type symptoms. There's actually, I don't consider that a side effect, but instead I consider it actually not only something that happens natural, but it's actually a good sign because it shows that your immune system is working. It's in the process of generating antibodies. And these are the types of things, the type of effects that you'll feel when you are infected and your body's revving up to protect itself with the antibodies. So I don't really consider that a side effect per se. Also, people might mention something about muscle soreness in the arm for a day or two. But generally that can be resolved after getting the vaccine with short doses of something like acetaminophen or some type of pain reliever.
When I got my vaccine, the first dose, I didn't even feel it. And I didn't have a headache. I didn't have any side effects or anything. After my second dose, for about 12 hours, I had some chills and some muscle aches. And you know what I said? Oh God, it's working. It's working. I felt really, really good, Dr. Burns. I'm not kidding. And then after about 12 hours, I mean, I felt like, oh man, I can do everything. I felt really, really good. It was working.
Let me say this. I had my second shot and it was less than the reaction I got from flu shot. It's just what you just described. And my doctor told me, he said, no, when it gets real sore, that means it's really working for you. So that's really a good sign. Now I'm wondering what it's doing. But let me do this because I want to, if I may, I want Dr. Hans Martin to give us some guidance here. But I have to tell you, I took my second shot at 17th and Broadway in the heart of the African-American community. And I walked into the place to take my shot. And I think there must have been about 40 people in there. And, you know, people were sitting around because they had to deal with the side effect issue you were talking about. But there were only 4 African-Americans. I counted them myself. As I left, I went to my car. I sat around. This is in the heart of the Black community. I sat in my car and I saw the same thing, people coming and going. This is a real issue. So I'm asking, I got 2 questions here for Dr. Hans Martin, and then anyone else can jump in as you see. And that is this: what is it that we can do, all of us that understand and know that this is something that we should do now? What is it that we can do that would encourage folks to get involved in protective behaviors? Because we're certainly all in this together. And then secondly, I would ask the question of Dr. Hans Martin, when do you think people will come if we employ these tactics or this communication skills or whatever it is you're getting ready to say? When do you think people will come so that we can have optimal participation by African Americans in this process?
Well, first, I want to start out with something a little hopeful. When we first started rolling this out, there was in the low 30% that people said, oh, I'll do this. I definitely am going to do this. They did reinvestigation the end of January, and now we're up, and it's like it's steadily going up. And I think the most important thing to note is people take a while to come around to change. Any kind of change you want them to do, it's going to take them a few steps. And this is a very drastic change in many people's mind. It has to do with a lot of their fears, a lot of the knowledge they had about how people were treated, and coming to some level of trust requires us to be trustworthy. And the things that I spoke about, which is talking about our experience, sharing the information as it changes, looking at all of the things that people have already done, given affirmations for those, and slowly walking them toward things. It's not going to be something that we can say, this is the magic statement to make. The fact that we're doing this and we're doing it over and over and over helps to make people feel more comfortable about the message they're receiving. So each time each one of you answered a question, talked about an aspect, reflected your own experience, that was a way to lower barriers and get people moving. And the longer it is between when the first people got their shots and how they are now, And when the next follows and the next follows, it's going to be easier to make that change. And so not only do we have to encourage people to do it, we have to be a little patient, even though we don't want to. We have to be just a little patient to let people get to where we are. We have to meet them where they are, but we have to wait and move them forward. So it may not be the answer you want, but it actually is how you get things going.
Well, I'm going to ask anyone who wants to pile on that question to do so. We only have a few minutes left. And at the end of that, I'm going to ask Dr. Hargett to ask the last question.
Well,
I
I want
just
to
wanted to
pile
add-
on. Oh, go ahead,
All right,
Vivian.
go ahead.
The only thing I wanted to say to add to that is I think the messenger is really important when we're
Mhm.
talking about the vaccine. And I stress that with my folks with the vaccine work group is people listen to people within their communities that they considered a trusted resource, right? We're looking at the faith-based community to host the vaccine sites. We're looking at our community centers. We're looking at those trusted folks within the community, right? And I'm telling people to think about, where do we spend our time? Ladies, we're in the hair salons, men, we're in the barbershop. That's where we get a lot of our information. Those models have been proven to work, to share education and information. So we need to start arming our community leaders, our lay community leaders, our lay health community leaders with accurate information. Help them tell that story. Make sure that they get their vaccine. So while you're getting your haircut or getting your hair, girl, I had it and I'm all right. So you need to go down and get yours too. I'll go with you. I mean, these are real conversations that I think we need to start having with folks in our community. So every chance I get while I'm sitting and waiting somewhere, I just ask people, what do you think about the vaccine? Have you had the vaccine? I've had mine. So and it starts a conversation. So I think we need to start having more conversations and really empower our messengers in the community to do better.
Anyone else?
I'm going to do a quick pile on that. And that is those of us in the healthcare field need to be patient with people who don't want to take it or want to know why we're trying to force them to take it. And take it slow, like Vicki said, answer their questions. They have a right to however they feel about the vaccine. Everything hasn't been good in the past, and it's not good now in healthcare and how brown and black people are being treated. So we need to be patient with them. We need to answer their questions, and we need to honor that they are at least asking us the questions. And as Vivian said, maybe we ask them, well, what do you think about it? And is there anything I can do, any question I can answer for you?
And Senator Neal, I go back to my original statement in the very beginning. Through transparent communication, ongoing conversations, and continued demonstration of trustworthiness in the community, we have to create this new narrative. And that new narrative will actually, I believe, help instill confidence in us as being leaders of the community and to show that these vaccines are safe and effective.
Dr. Hargett.
Yes, I don't necessarily have a question, but I'd just like to make a comment and really expound on what our other guests have talked about. And I think that, to get people to do things, they need knowledge. So I think they need to know what's going on. And with that, they need to have access. And so they need to have accessibility to getting things done once knowledge is done. And then they need to see examples. And so we're here tonight to give them and talk to them about examples of what as you mentioned, everybody on the panel has been vaccinated completely. And so they need to see others that have been vaccinated and talk to them and then have the knowledge that they can move forward to get themselves, as you say, in the best health status that they can get. And then they need to have access or the rollout on which they can get it done.
Well, with that being said, I want to thank Vivian Leslie Bibbs, Dr. Mark Victor Burns, Dr. Vicki P. Hines Martin, and Delana Manson. I want to thank all of you for participating this evening. The information that was provided was wonderful. There are certain things that we've learned from this conversation I think is kind of obvious, and that is that we must engage in protective behaviors in our community, and that includes vaccination. that we're responsible for each other, that we're not loners in this process. We have an impact on each other, and we all are needed to defeat COVID-19. I want to thank our panelists for the wonderful exchange that we've had here today. I'm already planning part 2 because this is not ended, and we're going to have to come back with the same panel and continue this discussion and reflect upon this sometime in the future. We're going to do that. I want to thank my co-host. I'm sorry, I want to thank my co-moderator, Dr. Lewis Hargett. I appreciate his expertise, his input in this process, and it's been wonderful with respect to that. And I want to thank our co-hosts, the AARP of Kentucky, the African American Initiative, of course, and I want to thank Sigma Pi Phi Psi Boule. That's the fraternity that's involved, that's been with us all the way. So with that being said, I want to thank our group that's behind the scene that nobody sees, certainly Alan Benson. You saw him pop in 2 or 3 times, but without him, all this would fall apart. And then even further, we have Brunhilde Carrington, who's doing a wonderful technical job, and we appreciate her input with respect to that. And there are others that you have not seen that are working behind the scene and pulling information together. So that being said, thank you and good night from the African American Initiative.